Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen, and thank you so much for listening today. On this episode of the Real Life Pharmacology podcast, I'm going to cover aminoglycosides. This is an important lecture within the BCPS and NAPLEX study materials. Go check out meded101.com/store if you're interested in checking out the study materials for those exams. We've also got ambulatory care content. We've got BCMTMS. We've got geriatric content as well as books, study resources, and materials for all sorts of different healthcare professionals. So again, the review course for BCPS and NAPLEX, this will be included with slides, of course, as well. These courses are over 30 hours of review content in addition to practice questions, supplemental resources as well, everything you need to pass your exam. Thousands of pharmacists, pharmacy students have been helped by our study materials. We absolutely think you can benefit too. So go check out all those links, meded101.com/store. Support the sponsor and, of course, help support this podcast. In this section, I'm going to cover aminoglycosides. These are an antibiotic for infection. I'm going to cover therapeutic drug monitoring, adverse effects, as well as indications with this class of drugs. All right, so the common agents that we hear of when we talk aminoglycosides are Gentamicin and Tobramycin. Amikacin is also a potential alternative here as well, but I would say gentamicin is probably the most common one you hear of, but tobramycin can be utilized as well. Mechanistically, aminoglycosides bind to the 30S ribosomal subunit, and this can essentially cause some misreading of mRNA, and ultimately that can lead to erroneous, if you will, protein synthesis. So essentially what this class of drugs does is it inhibits protein synthesis, or at least causes disruption in that pathway, which can ultimately lead to cell death. This class is bactericidal. It's got concentration-dependent killing, so we need those concentrations at certain levels typically to have that action of getting rid of the bacterial infection, if you will, rather than time-dependent killing, which is basically a certain concentration over a period of time that we need to hit that concentration. Concentration-dependent killing is where we get those higher concentrations. We're going to kill that bacteria more likely there. So hopefully that kind of explains the differences there between time-dependent killing, where you need that drug level at a certain level for an extended period of time, versus concentration-dependent. You get those higher peaks, for example. That's more effective in killing the agent. Spectrum and clinical use. These are often used as alternative agents for drug-resistant organisms, and I'll talk a little bit about spectrum coming up here. Can also be used in combination with some other antibiotics for a synergistic type effect as well. Active against aerobic gram-negative bacilli, including Pseudomonas. So this is a really, really big one in healthcare. It's a highly drug-resistant bacteria. The aminoglycosides do have some activity against Pseudomonas, so that is definitely a good thing and a nice reason to potentially use these medications. It's also got some activity against mycobacteria, also some synergistic effects. I've got a slide coming up here too that kind of lays that out. Commonly used for gram-negative infections, including complicated UTIs, potentially cystic fibrosis pulmonary infections, and infective endocarditis, usually in combination with other agents there. Listeria pneumonia, again used in combination sometimes with ampicillin, and ophthalmic infections can be an indication for these medications as well. Usually for ophthalmic infections, we're going to use eye drops, but just wanted to throw that in there. It does have some activity there. All right, a little bit more on spectrum. So synergistic effects, streptococci, enterococci, you may see this medication used. Pseudomonas, like I said, we do have some activity there, Tobramycin and Gentamicin for sure. And then, again, some of those gram-negatives, we can have some action there, like in the example of a UTI. Many UTIs are caused by gram-negative pathogens. All right, pharmacokinetics. It's typically administered IV. These medications may also be given IM. I occasionally see that in practice, not terribly often, but that can be a possibility as well. Distributes primarily into extracellular fluid, a relatively low volume of distribution, and in general, pretty poor penetration into the central nervous system as well as bone. So that's important to note there as well. Elimination greater than 90% eliminated unchanged in the urine. So knowing that, you can expect that this medication will likely accumulate or hang around for a long time as that renal function declines. So really, really important to pay attention to that. Patients with normal renal function, usually that half-life is fairly quick, in the neighborhood of a couple hours, give or take. Again, as that renal function declines, that half-life can be extended for sure. All right, let's talk dosing strategies. This is something that can definitely come up on board exams for sure. We've got extended interval dosing, traditional or conventional dosing, and synergy dosing as well. All right, so let's talk extended interval dosing. So essentially, this is where you give the medication, usually IV in a hospital type setting, but can rarely be in other settings as well. You give this medication usually once daily, once every 36, once every 48 hours, and possibly even longer in rare cases. But usually the 24 to 48 hour period, again, that's that extended interval between the dosages. Most gram-negative infections is where you might see this. It's easier administration, obviously. We only got to give it, let's say, once every day, for example. Therapeutic drug monitoring tends to be a lot easier as well. Uses higher weight-based doses with longer intervals. It maximizes that concentration-dependent killing. Again, we're getting those drug levels up higher and maximizing that effect. It also reduces, at least ideally, reduces the risk of nephrotoxicity and resistance potentially as well. Most common, in systemic infections, including, pneumonia or cystic fibrosis, a couple classic examples there. Traditional or intermittent, so this is maybe more considered conventional style dosing of aminoglycosides. Gram-negative infections, where extended interval may not be as appropriate. Lower dosages, shorter intervals preferred. Preferred in renal impairment or patients with unstable renal function, where maybe we want a little bit closer monitoring to make sure that we're not causing toxicity and issues there. And then we have synergy dosing, so usually these are lower dosages, but you may see that in the gram-positive infections, like streptococcus, for example, as well as probably enterococcus or staphylococcus, potentially too. The synergy dosing typically always going to be used in combination with beta-lactam antibiotics and or glycopeptides, excuse me. All right, so let's dig into this a little bit more. So why extended interval dosing? Again, maximizes that bactericidal killing, prolonged potential post-antibiotic effect. Drug-free period, 3 to 5 hours, which allows for renal recovery, and we're not causing insults to that kidney as much. So again, that can reduce that risk of nephrotoxicity. Lower cost, simpler monitoring, obviously, less administration. If you're in a healthcare situation or setting, less work for the nursing staff, less work for the pharmacy, and those type of things. Primarily, or when to use this, gram-negative infections is where you're going to see it often, and then obviously patients with stable renal function. Some inclusions or reasons that we might not use this extended interval dosing, pregnancy, or maybe less than 5 days postpartum. If patients have significant or severe burns to the body, generally considered greater than 20% body surface area, that's another exclusion. Severe ascites, where we're getting this fluid buildup, that type of thing, that's a potential exclusion for not using this. Creatinine clearance less than 25 mils per minute, or if we've got a patient that clearly has a rapidly changing kidney status or renal function, another situation there. And then prophylaxis or treatment of gram-positive infections. All right, let's talk extended interval dosing. So initial dose is in the neighborhood usually of 5 to 7 milligrams per kilogram for gentamicin and tobramycin. Interval is based on creatinine clearance. So with that extended interval dosing, if we've got a patient with creatinine clearance of greater than 60, we're typically going to use once daily dosing. If we've got it in the neighborhood of 40 to 59, it's probably going to be every 36 hours, 25 to 39, every 48 hours. And again, if that creatinine clearance is really low, we're probably going to use traditional dosing if we absolutely have to use an aminoglycoside. Now, there is a way to monitor extended interval dosing and adjust the dosing interval or confirm it with this nomogram. So it's called the Hartford Nomogram. And this is not necessary if the anticipated duration is less than 72 hours for the use of that antibiotic. So I think that kind of makes sense. But basically what you do is you draw a random level between 6 to 14 hours after the first dose. And then essentially you can use this nomogram to see where that concentration falls. And it allows you to recommend a dosing interval off of that concentration and the time that you took that. So if you want to Google search that, obviously I've got it on the slide here as well. But you can see based upon the concentration and the time between the start of infusion and the sample draw, we can get that, and that helps us determine or confirm the extended interval that we want to use, whether that be 24 hours, 36 hours, or 48 hours. So definitely kind of a useful tool there to kind of know and remember when trying to determine which interval to use there. Therapeutic drug monitoring goals, extended interval dosing, gentamicin, tobramycin, target peak. You might see 15 to 25. To get a little bit tighter, some institutions will use a tighter window there, ideally 17 to 24 micrograms per mil for that target peak. Target trough, less than 1, less than 0.6 micrograms per mil if institutions want to be a little bit more stringent there and try not to get that trough too high. So again, that's with gentamicin and tobramycin. With amikacin, target peak generally 50 micrograms per mil. Again, generally much higher than the other agents. Target trough less than 2 micrograms per mil. All right, traditional and synergy dosing. Conventional dosing indications, let's talk about that specifically first. So renal impairment, rapidly changing renal function, gram-positive synergy indications. and then extended interval dosing is not an option or not appropriate. Typical dosages for this: gram negative, 3 to 5 milligrams per kilogram per day, every 8 hours. Gram positive synergy, 1 milligram per kilogram every 8 hours. And then strep viridans or bovis endocarditis, 3 milligrams per kilogram every 24 hours. Interval based on creatinine clearance. Creatinine clearance greater than 70 every 8 hours. Creatinine clearance 40 to 59, Q12 hours. Creatinine clearance 25 to 39 every 24 hours. So as you can see, this drug is eliminated by the kidneys. So as that kidney function gets worse, we generally need to extend that dosing interval. Therapeutic drug monitoring. Again, we're talking traditional dosing here. Target peak. For severe life-threatening infections, pneumonia, we're generally going to target 8 to 10 micrograms per mil. Other gram-negative infections in that 6 to 8 range. UTIs, maybe in the 4 to 6 microgram per mil range there. Target trough is less than 2 micrograms per mil. Amikacin, target peak, potential life-threatening situation, 25 to 30 micrograms. Other gram-negative infections, 20 to 25. UTIs in the neighborhood of 15 micrograms per mil for that target peak concentration. And then target trough, severe life-threatening condition, maybe less than 10 micrograms per mil. And then all other indications, less than 5 micrograms per mil. And then in synergy, so typically less aggressive dosing here, Gentamicin, target peak, 3 to 4 micrograms per mil. Target trough, less than or equal to 1 microgram per mil. Just a little info on peak and trough. So peak and trough, usually we're going to get that around the 3rd or 4th dose. Peak is done 30 minutes after the end of infusion, and trough typically 30 minutes prior to the next dose. That's really our ideal targets. Now, in clinical practice, this can be difficult, and so if levels seem wacky or off or way different than what you expect in looking at these, definitely go back, discuss with nursing or whoever drew that level, what time did they get it, and pay attention to the times, because sometimes, obviously in practice, healthcare providers can get busy with what they're doing, and they may not get it at exactly the times that we want. So paying attention to that and understanding when that level was drawn, super, super important if something seems really, really wacky. All right, lab monitoring, renal function, obviously going to be super, super important. Typically, we're going to do serum creatinine on a daily basis, urine output, BUN as well. Therapeutic drug monitoring, okay, that's kind of a no-brainer. I just got done talking about that a ton. We're going to monitor the drug levels with this class of drugs. The other big thing to monitor for is ototoxicity. So this medication can cause, or this class of drugs can cause permanent hearing loss. So doing a baseline hearing assessment, repeat hearing tests during therapy, especially in higher risk patients, post-therapy hearing evaluation if we've got prolonged treatment, and then obviously the longer that patient is on an aminoglycoside, super, super important to pay attention to this. So if you got a patient on this medication for greater than a couple of weeks, that's a significantly higher risk patient than somebody that's getting it for 3 to 5 days, for example. So again, pay attention to that for sure with the risk of ototoxicity. All right, nephrotoxicity. So this can cause a proximal tubular necrosis. Risk increases with elevated trough concentrations, longer duration of therapy, greater than 3 days, for example. Elderly, dehydration, coexisting liver disease, and then, of course, other medications that are nephrotoxic, NSAIDs, ACE inhibitors, ARBs, spironolactone, diuretics. These are all drugs that can cause insult to the kidney. So, really paying attention to that and monitoring that renal function closely is important. Risk may be reduced with that extended interval dosing. Again, that's one of the primary reasons why we try to use that if we can, if the situation is appropriate for that. Ototoxicity, so auditory and vestibular toxicity, risk increases with elevated peak concentrations. Drug can accumulate in the inner ear. First symptom is often tinnitus, which is ringing in the ears, those type of things. Cochlear toxicity, it's a high frequency hearing loss, is typically what's going to happen first in this type of toxicity. Also, with the vestibular toxicity, we can cause imbalances and dizziness and difficulty with coordination. So really, really important to pay attention to those type of things with the risk of that ototoxicity, and this can be permanent. Rarely, you may see a neuromuscular type toxicity. In patients with myasthenia gravis, this can exacerbate that condition or potentially unmask it as well. GI, other adverse effects, GI effects, hypersensitivity reactions, eosinophilia, and anemia have all been reported with the use of aminoglycosides. All right, well, that wraps up this episode today. Please do me a huge favor. Go support the sponsor, meded101.com/store. We've helped thousands of pharmacists, pharmacy students, technicians, nurses, all sorts of people help prepare for pharmacology and for board exams in general. Again, all those links to those resources you can find at meded101.com/store. If you found this episode helpful, do me a huge favor, leave a rating, review on iTunes or wherever you're listening. I greatly appreciate that. And of course, share us, friends, colleagues, students, anyone in the healthcare field who could benefit from some pharmacology and medication education. If you have any questions or comments, reach out to me, mededucation101@gmail.com, or you can connect with me on LinkedIn as well. Thank you so much for listening. Take care, and I hope you have a great rest of your day.